So good evening, friends, and welcome you all. So basically now we are starting with our monthly academic meetings of ISCI. Every month in the first week, we will meet with some interesting cases, some journal club articles, and we will learn from each other. So this time, Dr. J.C. Mohan, who is a senior cardiologist from Delhi, has also joined. Sir, feel free to share your clinical inputs.
Thank you.
A few more people may be joining soon. We will begin with Puthivan's first case. He's from Coimbatore KMCH. Puthivan, over to you.
Thank you, ma'am. So today I'll just present a short case. This was a 65-year-old female. She was a known coronary artery disease, had a history of chest pain with ECG changes in 2015. At that time, a catheter angiography was done, which showed an RCA disease. It was a long segment disease, but they didn't stent at that point in time. It was done in an outside hospital. A balloon angioplasty was done at that time, and the patient was then medically treated after that. So the patient has been having some intermittent chest pain in between attending an OPD and was medically managed. So now the patient presented to our cardiology outpatient department with significant breathing difficulty. The patient was having exertional breathlessness, and she continued to have some on and off chest pain, which was not very typical of angina. So the initial investigations for this patient was done. The echo was normal, ECG, there were not much classical changes. However, in the echo, the cardiologist saw that the right atrium was dilated, and there was a suspicious constriction at the tricuspid annular level. The valves were normal, but he could see some external compression in the region of the tricuspid annulus, and the RA was dilated. So this patient was again referred to CT angiography for the dual purpose of again reassessing the coronary artery disease, and also to have a look at the pericardium to see if there is any constriction due to the pericardium here. So we did a CT angiography for this patient. Coronary angiography was done, and this is the images. As you can see here, so the patient did have a minor coronary artery disease, a few calcified plaques here and there, but the LAD and the LCX didn't have any flow limiting lesions. However, the RCA was looking a bit awkward. You can see that in the right atrioventricular groove, there is a round tubular soft tissue density lesion that was seen. So here you can see that the entire RCA is replaced by a cord-like structure. So it was starting from the ostium and then extending up to the RCA bifurcation. And you can also see that there is some amount of wall thickening. There is also extending into the aortic root, into the aortic annular region. And this particular cord-like structure was the one that was causing a constriction at the level of the right atrioventricular valve. And you can also see that as a resultant of this constriction at this level here, so this is the tricuspid valve, there is a supravalvular constriction here, and due to this the right atrium was also dilated. So this is again a curved reformat of the same patient. As you can see, this is the RCA. So the RCA was replaced by a long tubular cord-like structure, but still we were able to see a thin sliver of contrast enhancement along the center of the cord-like structure, which is supposed to be the RCA, and the RCA wall was showing a concentric thickening. Both the PDA and the PL branches were also involved. So this is the PDA, which is also again showing a concentric wall thickening. So since in the calcium score image itself, we observed that there was something fishy going on. There was some wall thickening and the RCA was looking a bit abnormal. So we had planned a venous space also. So this is the venous space run of the heart. And here you can see that the cord-like thickening that we saw in the angio phase is showing a homogeneous enhancement. So here again, you can see there is homogeneous enhancement of the wall. And there is also wall thickening involving the aortic root. So this is an eccentric wall thickening of the aortic root. So this is the left main ostium, which appears to be uninvolved by the wall thickening and it is patent. However, the right RCA ostium is completely obstructed. Here again, at the aortic root region, the right and the non-coronary sinuses shows this wall thickening, whereas the left sinus is free of any significant wall thickening. So here you can see this eccentric wall thickening extending from the annular level and ascending along the ascending aorta, and the opposite side of the root was comparatively uninvolved. Again, the ascending aorta showing this eccentric enhancing wall thickening. So with these findings, so we had a diffuse wall thickening of the RCA and its terminal branches with homogeneous enhancement and a critical long segment narrowing of the RCA. Because of this cord-like thickening of the RCA, there was a supravalvular constriction on the right side with the dilated right atrium. And the eccentric wall thickening was also extending into the aortic annulus, into the aortic root and the ascending aorta. So this was a 65-year-old patient. So, but still we considered the possibility of a coronary vasculitis, which was involving only the RCA. The left main LED and the LCX were uninvolved with associated aortic arteritis. So we asked for further investigations of the patient. So blood investigations revealed a raised ESR and a raised CRP. We also did a full immunological workup to look for any other connective tissue disorder. So the ANA, anti-dsDNA, and the ANCA, everything turned out to be negative. The next step, we then went ahead and wanted to do a PET scan to look at any other focus of involvement in the patient. So a PET scan, an FTG PET was done, and it showed a significant increased uptake in the areas of the wall thickening around the aortic root, in the AV groove, in the regions of the RCA. And the PET also showed that there was significant concentric wall thickening of the abdominal aorta also. So you can see the abdominal aorta is also showing wall thickening with an increased uptake. This is the aortic bifurcation, again showing wall thickening and increased uptake. There was no other area of uptake or abnormality in any of the other organs in the PET CT. So a diagnosis of an inflammatory pathology, likely vasculitis like giant cell arteritis, was made. The patient was put on steroids and immunomodulators, and 2 months follow-ups was done for this patient, and the patient was symptomatically better at 2 months. The ESR and CRP had reduced. The CRP, which was in the 30s, had come down to the almost normal. In 6 was the normal in our center, and it was around 7 milligram per liter after 2 months of steroid therapy. So when we talk about coronary vasculitis, we usually consider it to be a children's disease, where we see a lot of Kawasaki's in young kids. But coronary vasculitis can also occur in adults, though the most common coronary vasculitis that occurs in adults are Takayasu's, IgG4 disease, and polyarteritis nodosa. Giant cell arteritis is kind of rare compared to the other vasculitis. But since this was an older patient, more than 50 years, and had a diffuse involvement of the RC, so we considered the possibility of giant cell arteritis. So the other vasculitis that has to be considered, especially in adults, are Takayasu's arteritis, when the onset is less than 40 years. So it shows an increased ESR and CRP, and it has a more prone to involve the ostium and proximal segments of the vessels. Giant cell arteritis again can involve the entire vessel, or it can also present with skip lesions, and it also has a propensity to involve the larger vessels also. Polyarteritis nodosa again can present with other visceral organ involvement. It presents with alternating aneurysms and areas of stenosis, giving the classical beaded appearance. ANCA vasculitis, again, patient will be ANCA positive, and they can have other involvement, more commonly renal glomerulonephritis is more common in ANCA vasculitis. IgG4 disease again is another rare disease which we often encounter, which can involve any organ. IgG4 disease is not limited to any one particular organ. It can involve anything from CNS to the lungs, to the vessels, to everything. So these are the main differentials we'll have to consider whenever we suspect a case of vasculitis involving the coronary arteries, especially when we are encountering an adult patient. Thank you very much. So can open to discussion, and you can share what else you guys can think of in this particular patient, or anything that I could have done differently.
What about the IgG levels?
So the IgG and all the immunological workup were all turned out to be negative, sir. The ANCA, the other all autoimmune panel that was done, everything was normal, was turned out to be negative.
No, the IgG is nothing to do with the autoimmunity. What we are saying is, in absolute terms, I mean, you did do a immunofixation and maybe the immunofluorescence study to find out how much is the level of IgG. I mean,
so I don't remember the exact levels, sir, but the immunofixation and these tests that was done in this patient turned out to be normal, is what I remember.
The other thing is, I think since we don't have a biopsy, we should not call it giant cell arteritis. We should call it non-specific vasculitis. Yeah, yes, sir. Biopsy kind of was difficult to convince the patient to get a biopsy done for this in this particular case. So that's why we was the most probable diagnosis is what we felt was that, but still we don't have a HPE diagnosis for this patient.
Buddhiman, very nice case. By any chance, could you look at the images of 2015 catheter angiography or CRP?
No, that was done in an outside hospital, ma'am. So we didn't have access to those images. I tried getting it from the patient, but the patient didn't have it.
Yeah. Sir, catheter angio would be abnormal, no? In these cases, would there be any pictures?
No, it must be diffuse involvement. My guess is that this is an atypical variety of aortoarteritis. We have seen what I call it onion peel appearance of the coronary artery with marked thickening of the media and intima and very, very narrowed lumen diffusely. We have seen some cases of Takayasu disease like this. This is more often you have seen in carotid arteries. Absolutely like this, string-like lumen and very thick walls in both the carotid arteries we have seen quite often, and the aorta involvement. I've seen one case of IgG aortopathy, which had exactly a picture like this, but not right coronary involvement. So I think the theme is same.
Yes. So even when I was looking for literature, I couldn't find much literature where there was a coronary involvement like this. There were, as you said, carotid involvement was very much common with this particular appearance, but coronary was, I also couldn't find any significant amount of literature on this particular type of involvement. Absolutely.
This is a phenomenally good case actually to present and to publish also.
How do we get the histopathologic diagnosis in these cases? Coronary artery histopath would be so difficult.
Yes, that is a challenge actually. I still feel that we could have done a biopsy of maybe temporal artery or something like that, even though that PET did not show it. We could
Yes.
probably pick up something actually somewhere.
Okay, so,
You know, I
okay.
mean, it's a wild thought, but you can't really say. You know, our difficulty is pinpoint the type of aortoarthritis. It is aortoarthritis. There is no doubt about it. Now it is vasculitis plus aortitis. There isn't any doubt. Question is pinpointing it, the exact etiology.
Exactly. Yes, sir. Exactly, sir.
And it doesn't change the treatment. It doesn't change the treatment actually. But one of the things which you have seen over a period of time, that the so-called non-specific aortoarthritis or Takayasu disease presents in myriad ways. So many different ways it presents, and it keeps you, the aneurysmal variety, the vascular variety, aortitis alone, and it's actually quite interesting. And such a thing we haven't seen in tuberculosis. I mean, if one starts thinking in those lines, haven't never seen it. But this appearance of right coronary artery is, I think, striking. I've never seen it.
Yes, yes.
Never seen it.
Okay, so we move on to next case. Dr. Bansal is also joined. Welcome, sir.
Thank you. Thank you. I'm happy that I'm able to make it.
Yes, yes. So I will proceed with my case and then we will move on to your talk, sir.
Good evening, sir.
Good evening.
Priya ma'am, you are not audible.
Okay, sorry. Okay, so this was a 65-year-old female who presented with breathlessness and edema feet, right lower limb more than the left limb. Actually, she happened to be mother-in-law of a cardiologist. So every year he used to follow up on the 2D echocardiography. So when this time she came and she presented with edema feet, the next thing he did was a 2D echo, and where he could figure out that there is some mass lesion near the tricuspid valve, and hence cardiac MRI was done next day. So as we see on this 4-chamber cine images, there is a lobulated mobile mass near the tricuspid valve annulus. It is moving and prolapsing into the right ventricle. Moreover, you can see there is some thickening of the adjoining myocardial wall as well. Short axis cine images, you can see that signal intensity is similar to myocardium. The margins are lobulated, frond-like. There is some infiltration all along the myocardial wall. This wall thickening was something abnormal. Zoomed out views of the short axis images. Here we can appreciate there is thickening along the right atrial wall. RV views again confirm the mass is pedunculated with this is a small pedicle where it is prolapsing into the right ventricle. So these are perfusion images, and as we can appreciate, there is some mild vascularity on a perfusion scan. There was patchy delayed hyperenhancement. So as we can see, these are the late gadolinium enhancement images, some vascularity, and there is thickening along the annular plane as well. Very thin rim of pericardial effusion. Again, we can see this long axis views of delayed enhancement with some enhancement, delayed enhancement of the lesion. TI 600 was obtained just to rule out any thrombus, but it did not remain dark as we see in this case. So as a protocol for every cardiac mass, it is important to look for CT images to look for calcification. There was no calcification, but incidentally we picked up this nodule in the breast. So there was this nodule in the breast, and on the MR images, even the nodule had shown some kind of enhancement. But as we see, the margins are very smooth. Immediately patient underwent bilateral mammography, and this is the mammo image which shows a lobulated lesion but with smooth margins. But however, in MLO view, the margins were obscured in one plane. This was the sonography picture. This is not classically looking like benign. There are some internal echoes, some front-like projections along the periphery. And hence the PET CT scan was done. On the PET, there was significant uptake in the cardiac lesion. The uptake was also present along the right atrial and right ventricular margin near the annulus. The breast lesion also showed significant uptake. But most importantly, there were multiple lymph nodes which were all throughout, all on the right side, prevertebral, paravertebral, as well as large lymph nodes in inguinal region. This was the breast lesion, this was the cardiac lesion, and this was all along the right atrial wall. But most strikingly, all lymph nodes, and there was some uptake even in the calf muscles, left as well as right side. So these were the images of the PET scan, again significantly showing uptake in the lymph nodes. The edema of the right lower limb probably would have resulted from these large inguinal nodes, which were compressing the femoral vessels. The uptake in the calf muscle was also evident, but however, even on a going back, patient did not have any pain, swelling, no injury, nothing was evident. So then finally, the biopsy was done from the breast mass along with immunohistochemistry, and it revealed diffuse high-grade B-cell lymphoma. So this was a type of non-Hodgkin's lymphoma. The pathologist was not sure because it was so diffuse involvement that whether it was primary cardiac or a cardiac was a secondary metastasis, because it had already gone to the lymph nodes, but the breast lesion definitely looked secondary to them. And the treatment is usually with surgery and chemotherapy. But however, even with chemotherapy, there is the literature reports significant recurrence. Depending on the hemodynamic disturbances, decision of surgery can be done. So the key message is just not limiting to one organ, and sometimes connecting the dots can give a complete picture. So initially I used to feel that, as a radiologist, we are at a disadvantage that we do not see the patient clinically. We do not, but sometimes probably we can connect the dots better. I'm open to discussion. Yeah.
Excellent case and very well worked up. I think completely worked up, and that is the beauty of this case. So well worked up, right from beginning till end. There are no loose points. There are no dots to connect any further. Absolutely fantastic.
Thank you, sir. Sir, do you think this is cardiac thing is primary or secondary in your opinion?
So primary lymphomas are known actually, and they can actually metastasize here and there, including breast. So it will be interesting actually. Somewhere in very early 80s, I saw a case who had a mass like this, and he also had actually a mass on the olecranon process, in fact, and some lymph nodes here and there. So we actually got his biopsy done of a mass on the olecranon process. It turned out to be non-Hodgkin lymphoma. The other lymph nodes were so, and we thought that since the biggest mass was in the left, in the ventricle, in the right ventricle, exactly same place, we said it was a primary lymphoma of the heart, and we tried to get it published. That was 42 years back exactly. And the editor said, well, there are about 50 such reports already in the literature. There is no fun in publishing it. So one of the things we realize is primary lymphoma or lymphomas of the heart are not uncommon, and they can actually metastasize like this.
Okay, thank you. Anyone else has any comments? Dr. Babu, Dr. Bhavna, Dr. Parul, Nilay? Okay, so otherwise we move on to our next speaker. So I invite Dr. Manish Bansal. He's from Medanta, Gurgaon. Sir is the chief editor of the Indian Journal of Echocardiography, and he has been very supportive in terms of all our academic publication. Sir, so basically these are all around 15-20 of us are there from different parts of the country. All are radiologists, but into cardiac imaging. In fact, there are few senior members, but who are unable to join today, but the meeting is being recorded and they will be viewing it later on. But I just tell my fellow colleagues that this part, probably what we are missing in India, we definitely need to work on this. And so many of us have good cases. We need to go ahead in doing some academic work. And I'm sure this association with clinical team would take us ahead. Sir, over to you.
Yeah, definitely. So, good evening, everyone. And thank you, Dr. Priya, for giving me the opportunity to discuss this very important topic. As we know, we are going to talk about certain aspects that we need to take care of when we are writing papers for publishing in various journals. I'll be talking mainly about original article, but the fundamentals apply to any kind of article being considered for publication in any reputed journal. So first thing that I would like to mention here is that writing a good manuscript is extremely important in getting a manuscript published in any good journal. In fact, there's no doubt that data and the concept of the study is also very important. But manuscript writing is equally important, maybe even more important. If we have good data and we write the manuscript very well, then we can get our study published, our paper published in one of the very good journals. But if our data is weak and concept is weak, but still, if the manuscript writing is very good, we can still get into a decent journal. But on the other hand, if we have good data, but if we have not written the manuscript properly, then it will be very difficult to get into any decent journal. Maximum we'll be able to get into a low-level journal. So that is how important the manuscript writing is. Obviously, we need to make every endeavor to get good data and good well-written manuscript to get the best outcome. So before I talk about manuscript writing, just briefly about how to select a research question for any kind of original study. See, when we decide about a topic for any original work, especially for DNB students, the usual thought process is, let us take a topic which I can easily do, or what paper I can easily produce. That is how we think, but that is absolutely wrong. See, we need to think that once we submit our manuscript to any journal, the editor will look at the paper's interest, look at whether the paper will be interesting to the audience of that journal. So if we are doing something which has already been done, we have done this study only because we could easily do it, that will not make audience interested in the paper that we are trying to publish, and the journal is not going to accept. So every time we should try to think how we can answer any unanswered clinical question, or we can address some unmet clinical need. If we do that, then that will immediately make our work very, very relevant to the audience and will improve chances of publication. So just to give you an example, we get many patients undergoing liver transplant at our hospital. So all of them undergo echo, and in echo we have many fancy parameters like strain, myocardial work. So it's very easy for us to do a study in 50-60 prospective liver transplant patients and do a strain and myocardial work. And once we do that, you see, when we go to submit this paper, initially, if there is no such paper available, no such information, then we may get into a reasonable journal But very soon, there will be papers on this. And if we see whatever we are trying to do today, we need to remember that there would be many others who would have already done that. So if we are just trying to repeat strain imaging in cirrhosis patients, no good journal will accept. But if we try to correlate these parameters with clinical outcomes, then it will become immediately important and the chances of publication will improve. So every time, whenever we are seeing patients, we are busy in our clinical practice, we should try to see what problems we are facing in decision making in our day-to-day clinical practice, and then we should try to find research projects or ideas for research projects from those clinical situations that we encounter in daily clinical practice and try to address those challenges. Now, the next step is to select an appropriate journal. And that comes before we start writing the manuscript, actually, because although the main content of the manuscript is going to remain the same, but there are going to be some finer aspects which will vary from journal to journal. And therefore, we need to first decide which journal we are trying to target, and then accordingly, we'll write our manuscript. So whenever we look for any journal, obviously all of us want every manuscript of ours to get published in a journal which is indexed. And by index, I mean Medline Index or a journal which is on PubMed. Obviously, that is our goal, and we must every time try to achieve that. Now, how do we find out which journal is on PubMed? Most of the good journals mention this on their website, but the other more foolproof method is to do a search on PubMed. Try to look for that journal, type the name of that journal in the PubMed search box, or try to look for articles recently published in that journal on PubMed. If we find those articles there on PubMed, then that will confirm the journal is on PubMed. The second point that we need to look at is impact factor. Now, every journal which is on PubMed does not necessarily have an impact factor. This is what we need to remember. For impact factor, we may have to make a separate application to Clarivate, which maintains and releases impact factors of all the journals. Clarivate has a separate database known as ESCI, Emerging Sciences Citation Index. Only the journals which are included in that database will have impact factor. Now, most of the journals which are on PubMed, many of the journals which are on PubMed will have impact factor, but not every journal. And this is something which we need to remember. In many cases, you'll find that that impact factor is mentioned somewhere on the journal website, but that may not be a true impact factor. However, not having an impact factor is also not such a big problem. There are many good journals which are on PubMed, which are indexed, but do not yet have impact factor, and they may still be a good vehicle for our publication. Now, another point related to impact factor is that the journals which are related to broader specialty, like medicine journals, they will have higher impact factor because the articles published in those journals have more opportunity to get cited as compared to a specialty journal, and the subspecialty journals will have even lower impact factor. So just to give an example, journals like NEJM, Lancet, Nature, they have impact factors in the range of 50-60. Cardiology journals like JACC, which is the topmost cardiology journal, or European Heart Journal, their impact factor is in the range of 20 to 25. But if you look at Echocardiography Journal, the American Society of Journal, which is the leading echo journal, it has impact factor around 7-8. So that will determine what the impact factor is. Most of the journals that we usually target will have impact factor of around 2, 3, 3.5, which is actually a pretty decent impact factor. But at the same time, when we choose a journal, we need to be realistic about our work also. I've seen many authors trying to look for very high-level journal when the data that they have is not that strong, or the manuscript that they have is not that good to get accepted in that kind of journal. So there's no point trying to go for a very high level journal, because then it's just a waste of time and effort. The manuscript will get rejected immediately. I've also seen many authors trying to submit to higher journals just to get feedback from those journals, and with the belief that, okay, what happens if the manuscript is rejected? There's no problem. We'll still get some inputs from the journal, from the reviewers, which we will use for improving our manuscript. But actually, in reality, that does not happen. Whenever a manuscript is rejected, authors don't make changes in their manuscript according to those comments. They just submit it to another journal. So it is basically time waste. We should not try to do that. Other important point while choosing the journal is the scope of the journal. Whatever work we are trying to publish, it should match with the scope of the journal. Otherwise, the chances of rejection are going to be high. For example, if I have a study which is heavily dependent on strain imaging, then obviously it has to go to a cardiology journal, or preferably an imaging journal, cardiac imaging journal, rather than general medicine. So if I send that kind of manuscript to JAPI, it's likely to be rejected because it's not going to be attractive to the editorial board of the journal or the readership of that journal. Now, another important point is that we always try to go for international journal because we want to have international publication. But many times it is even more important to reach out to our own peers. There's a lot of work which needs to be communicated to those who are interested in that work, rather than trying to go for an obscure international journal, which none of us around us are going to read. So, for example, if I have a good case report and I try to publish it in some Japanese journal or some Gulf journal or Italian journal, just because those journals are international journals, it may not have the desired impact on our peers. And for some specific work like guidelines or data which is originating from India and is relevant for Indian population, there's obviously no point going for international journals. Then another very important point when choosing a journal is timeliness of peer review and publication. This actually is a very, very important part, because if the journal takes months to respond to the initial submission, and another several weeks for making a decision on this revised version, and then several months before the manuscript is finally published, then that again is not a good option. Also, very, very important is to be very, very careful of predatory journals. Predatory journals are those journals which do not have any scientific foundation. They are only there to earn money. And therefore, whenever we choose any journal, we need to make a good, thorough search before we submit our manuscript to that journal, unless we already know that journal. If we go to the journal's website, whatever is written on the website is of no meaning, because these predatory journals, they will also mention so many databases where they are indexed. They will mention impact factor also, which are not true impact factors. So best is to look at many databases of predatory journals which are available on the website on internet. You just do a Google search predatory journals, or other option would be to just look at the PubMed website, as I mentioned earlier. There are two reasons why we need to stay away from predatory journals. First, obviously, is money, because what happens is that once you submit your manuscript to any of these journals, the manuscript will promptly get accepted, and then you will start receiving emails for submitting submission fee, for paying of a submission fee. And if you don't pay that, you will be harassed like anything. And the second reason is that all the important databases like PubMed or Medline, Scopus, DOAJ, Clarivate, all of them ask the editors to select only those people in their editorial board who do not have any affiliation with any predatory journal. So if you have published a paper in a predatory journal, it will become very difficult for you to get included in editorial board of good journals. So that is another reason why it's very, very important to stay away from predatory journals. Now then comes how to write a scientific manuscript. So one point which most of the authors do not consider that important is language. And I'm mentioning this as the first point because in my opinion, having language accuracy, good writing is extremely important in influencing the editor and the reviewer's opinion about the manuscript. If the manuscript is written in very poor English, there are lots of abbreviation errors, lots of uppercase letters used for no reason, and so on, then it leaves a very bad impression on the editor and reviewers. So this must be taken into, this must be given full attention. Then the next important thing is that whatever we write, it should be coherent and there should be a clear flow of thoughts. So the questions that we raise in introduction must be answered by our results. Whatever we mention in results must be explained in discussion. Whatever we conclude should be based on our data. Whatever we mention in methods should be consistent with what we are showing in the results, so on. So all the components of the manuscript must be in sync with each other. That's very important. Another point is avoid exaggerations. I have seen that in case reports, many authors are in the habit of writing first ever publication, unique case, and something like that. Actually, these kind of exaggerations are not needed. They create a bad impression on the reader, and they don't get you any extra credit. And also, sometimes when we write first publication, it's never been reported in literature. We may not be aware actually that such a case has already been published. So in that case, it becomes a very big problem if that kind of manuscript gets accepted and the author of the initial publication stakes a claim or mention or highlights this error. So then it becomes very difficult to withdraw from that. So there's no better to avoid exaggerations. And also it's extremely important to make sure that we never compromise on publication ethics. We should not fake data. We should not plagiarize anything. We should not use copyrighted material. Because first of all, if we do that, it's very likely that no good journal will accept the manuscript. And secondly, even if we are able to publish our work in a lowly journal, this may create problems later on if someone finds out that what we have published is all plagiarized. So always stay away from these things. Then when we are writing a manuscript, particularly an original article, what we should do is, first we should prepare tables and figures. Because this is easiest. We have our data, we know what we want to present. So best is and easiest is to prepare tables and figures. Now, once this is done, then start writing results. Once results are written, then we need to write methods. In methods, we have to describe how we have obtained these results. I'll come to that in the next slide. So if we already have results in front of us, then we know what all we need to explain. So then writing methods becomes relatively easier. And then we need to write discussion and introduction. We can do this in any sequence, but this is how we should go. First tables and figures, then results, then methods, and then discussion and introduction. And finally, we need to write an abstract, which is nothing but a summary of the paper. So when we are writing introduction should never be too long. Maximum 2 or 3 small paragraphs. We need to describe what is known about that particular topic, what is missing, and how this study aims to address this knowledge gap. That is it. We don't need to describe methods. If we are using any special technique like strain imaging or myocardial work, we don't need to go into those details. We can just mention that nowadays it has become possible to assess cardiac function using speckle tracking echocardiography, and it allows us to calculate myocardial work also. That is it, nothing more than that. Everything else will come in either methods or discussion. Then in methods, we need to describe exactly how we have conducted the study, how we have selected our subjects, what were the inclusion criteria, exclusion criteria, from where we have included them, what we did with those subjects, what all tests were done, how they were done, what data we collected, how the data was collected, and how analysis was done. Basically, if any third person reads our methods, he or she should be able to reproduce our work. That is how we should write methods. Then comes results. In results, we need to describe only those findings which are relevant to our work. When we do analysis, we generate host of findings, but it's not mandatory to present everything. In fact, we should not try to complicate results too much. So, for example, I recently came across a work in which two different kinds of parameters were compared, but the author tried to create multiple subgroups of both the parameters, and it became very, very complicated. So that kind of complexity should be avoided. We should just describe key results and then group them under relevant headings. So we can describe baseline characteristics, then overall findings, then key group related findings, and likewise. We should try to have decent number of figures and tables, but avoid duplication. So whatever has been presented in figures should not come in tables, and vice versa. And whatever we describe in figures and tables should not be repeated verbatim in the text. In text, we should just summarize key findings from the results if we have already shown that data in tables. Now in discussion, the main goal is to discuss key messages of the study, their implications, the findings that we have got, are they consistent with what is already known? If not, then what could be explanation of our findings and how they are relevant for future work. So that is what we should discuss. We should not try to discuss each and everything that we have seen, we have found in our study, which is something that most of the DNB students do. What they will do is they'll describe that, okay, we had in our study mean age was 50 years, and then they will describe 5 other studies in which the age was same. Then we had 60% males, and they will quote some studies which have had the same kind of gender distribution. That is not discussion. Discussion is messages from our study. Then it's extremely important to discuss limitations. We should have a separate headings in which we must describe limitation of our study. And why it is important is that when we write limitations, then any reviewer who reads the paper, he or she immediately comes to know that the authors are not trying to make false claims. They are not trying to befool the audience. They are aware of the limitations of their work, and they are honestly presenting that. And also when we summarize, when we discuss limitation, it gives us opportunity to already give explanation for the problems that we have in our work, rather than making the reviewer ask the same questions and then adding it. So always summarize limitations. Then conclusions, again, we need to describe key messages. No data should be presented in conclusion, and whatever we write in conclusion should be supported by whatever we have shown in our results. And finally, abstract, which is, as I mentioned, only a brief summary of the paper, and it must be self-sufficient. If anyone reads the abstract, he should get the gist of the paper without having to go through the entire paper. So this is how we need to write the manuscript, but our job does not end with initial manuscript writing and submission itself. There will be another very important step in publication process, and that is revision. So actually what happens once we submit any manuscript? The manuscript is initially reviewed by the editorial board, and for most of the leading journals, most of the manuscripts are rejected at that level only, which is known as desk rejections. The lower the level of the journal, lower will be the desk rejection, but desk rejections happen. If the editorial board finds merit in our paper, then the paper will be sent for peer review. And once peer reviewers provide their inputs, the editorial board will take a decision on the paper. Now, this decision can be acceptance or need for revision or rejection. In most of the cases, no manuscript is accepted in the first go itself, because every manuscript has some deficiencies which we as authors become blinded to, because we are writing the paper. For us, everything looks good. But whenever any third person reads that paper, he or she will find some deficiencies which will have to be addressed. So it is very unusual to have acceptance in the first instance itself. And therefore, if we get a letter for revision, then it is a matter of being happy, not disappointed. Many authors become disappointed that their paper was not accepted, and the editor sent the paper back for revision. But as I'm saying, if the editor has not rejected the manuscript, it means that the editorial board is interested in our paper. And now it is entirely on us how we revise the paper and make sure that the paper gets accepted. So revision means a half foot in the door, basically. Another thing is that when we receive the revision letter, many times the revision letters are long and there are many corrections being asked for. And many authors get irritated with that. But let me tell you, this again is a very wrong way of looking at it. We need to remember that whenever any work is published in any journal, then after publication, that work becomes a reflection of the editor and the journal's credibility, not that of authors. So to give you an example, if you take a paper from NEJM and it has lots of deficiencies, we will not look at the names of the authors. We will rather say what is happening to NEJM, what kind of papers or articles are being published in NEJM, or how could NEJM accept this? That is how we will look at it. If the article is very good, then we might look at the names of the authors, that okay, this paper is written by this person, so obviously this was expected to be good. But for any bad work, it is editor and the journal which get the bad name. So because of this reason, editor always wants to make sure that whatever is being published is of best possible quality. So once the editor has decided to publish any paper, then he or she seeks author's help in doing those revisions so that the final product is worthy of publication and does not bring disrepute to the journal or to the editor. So editor is trying to help the author, and author by revising is trying to help the editor. So it is a symbiotic relationship, and it must be viewed in that light only. So whenever we get any paper back for revision, we must take that job with great sincerity, and we should do all the revisions with meticulousness. Whatever is being asked for, we should try to address those issues. Sometimes the reviewers ask for certain things which are not possible, and we become disheartened that okay, we are not able to do those revisions, so our paper will not get accepted. That is not true. We must provide honest explanation for whatever we are not able to do. If the editor is otherwise satisfied with the rest of the content of the manuscript, then the editorial board will make provisions for accepting those papers also, with limitations highlighted in the paper. So that will not be a reason for rejection. But trying to give false excuses or misleading excuses, that will lead to more problems. Then, as I mentioned, avoid plagiarism and copyright infringements always. And even if by mistake we have included something which infringes on copyright, or there is some plagiarized content, and the editor has asked for correcting that, that must be corrected with utmost sincerity. Many times what authors do is they will just write, we have rectified plagiarism, but the manuscript has not been changed much. And that tells the editor that not only the authors were not careful initially in when they were preparing their manuscript, they're not bothered now also. And most of the times, such manuscripts will get rejected. Then, as I mentioned in the beginning, language is very important. Take language correction seriously, because we also need to understand this, that most of the journals do not have good copy editing team. Many authors believe that, okay, whatever we are trying to submit, if it gets accepted, then it becomes the responsibility or headache of the journal to correct it. But you see, as I said, most of the journals don't have copy editing team. So what will happen is either editor will put in all the effort to rectify those errors, or the paper will get published with all those errors. And then it will become a matter of, feeling bad, or I could say shame, if we find that our paper is published with lots of errors. So it's best to correct those things in the beginning itself, rather than being in that difficult situation. Then when we are revising our manuscript, we also need to submit a revision letter. Now, this again is a very, very important document, and a good revision letter plays a very important role in shaping the editors and reviewers' opinion about the author and their work and final outcome. If we write revision letter very well, then even if we have lots of deficiencies in our manuscript, and if there are many issues which we could not address, still paper will get accepted. But if we just write corrections done, corrections done, correction done, then the chances are that the manuscript will get rejected. Because why would reviewer take that much pain to go through the paper to find out what changes we have done, whether those changes are reasonable or not? Also, when we are writing the revision letter and we are giving an explanation, we need to use a balanced language. We don't need to appear combative, arrogant, saying that whatever we have done is right, this is how it should be done, or something like that. But at the same time, there's no need to be too submissive either. There's no need to say that honorable reviewer, or we are extremely grateful. Those things are not needed. We thank the reviewer for providing this valuable input, and we have corrected it appropriately. That is how we should reply. As I mentioned, we need to address each point raised by the reviewers and editors, respond to each point diligently, provide explanations as needed, and highlight all the changes in the manuscript. This is again very, very important. And lastly, once the paper is accepted and has undergone initial copy editing, and it has come to us for proof corrections, this also should be taken seriously, because this is our last chance to ensure that the paper that is being published does not have errors. Because when we do corrections and we submit it, we think that we had already rectified all the language errors and other errors, so there should not be any need to do proof correction. But that is not true. When copy editing is done, many errors creep in for a variety of reasons. Many times the copy editor, because they don't have that scientific background, or they don't have subject knowledge, they make many errors. They will expand abbreviations wrongly, or there will be misplacement of text or figures, or figure legends may get changed. So all those problems creep in, and therefore we should do proof corrections also very sincerely, go through the paper in entirety and make whatever corrections are needed. And we need to be prompt, because any delay in submitting proof corrections will delay publication of our paper. So it is entirely on us to ensure that the paper is published promptly. And lastly, this entire process of doing a research work and publication requires inputs from a variety of sources at different levels. And therefore, it's very important to collaborate. So for example, there are many people who have got good case material or good data, but they don't know how to write well. So they can collaborate with people who are good in writing. Similarly, there are many times when we need large sample size, but we alone are not able to do that. So we can collaborate with other peers to develop multi-centric data. So that is how we can collaborate with like-minded people who can add in different capacities to build a good paper, a good research study, which will help in getting us many more publications. Thank you.
Thank you, sir. That was really excellent talk, sir. Really, thank you. Sir, just one small question. As an author, as a beginner, like sometimes when we publish an article and you get that your article was quoted in this journal, those mail, what is the significance of that?
So you see, that means that your paper was cited. So first, it should make you happy that someone was interested in your paper and cited it. Now, beyond that, it becomes relevant when we look at our research credentials and research metrics. One of the metric is H-index, for example, which is used for assessing the level of any person who's been publishing, academic level of that person. So what H-index means is number of articles that are published that number of times. So if my H-index is 25, that means I have at least 25 articles which have been published, each of which has been published at least 25 times. So if we get more citations, then our H-index will go up. More citations means we are more widely known amongst people who belong to the same area of interest. So that's what it would mean.
Sir, and about the ResearchGate, like, whether to publish the article on ResearchGate, I mean, what is the clinical scenario of the ResearchGate article?
You see, we should not put full text paper on ResearchGate unless the journal in which that paper has been published allows us to do that, because ResearchGate is not truly an official database or a resource. If we publish any paper there full text, when the journal has not allowed open distribution of full text paper, then it is a copyright infringement and we can be in trouble.
Sanjay sir, are you there? Anyone else has any questions?
Yeah, hi Priya. I just joined at the last minute because
Yes.
I was in the middle of a different meeting.
No issues.
Nice to see Manish and hear him speak about something which is very important to all of us in terms of moving forward with what we're trying to achieve. Don't really have any major comments because I missed most of the thing, but I think this is a very important topic that he's talking about.
Yes. Anyone else has any questions? Yeah. So we probably as a community, we should definitely take more initiative and write more papers and do some original research work.
Yeah. And also I would like to say that we should try to keep publishing, even if we initially get into only a not very high level journal, because every publication is a huge learning exercise. So more we publish, better we become at publishing.
Yeah. Yes, sir.
I don't.
Manish, the biggest hurdle in publishing, and we had discussed this issue several times, and at various fora, why Chinese are producing so much or Japs are producing so much, we don't publish that much, is a lack of incentives. Besides personal satisfaction you and me get from writing a paper and that being quoted, it doesn't translate into any material benefits. All over the world, it translates into material benefits, whether it's United States or Europe. But in this country, unfortunately, there is no weightage given to publications. And of course, this is, and even if you want somebody to give weightage, the why I'm raising this issue is that you and me and many others are in private practice. It doesn't make a difference whether we publish or not. But there is an academic milieu actually. A lot of people work in these teaching institutions. They were supposed to publish high quality work and keep our flag flying. Over a period of time, it became what is called as time-bound promotion. 3 years an assistant professor, you become associate professor. Another 4 years associate, you become professor. Now, all you needed was a very good report from your professor. It didn't make a difference how many papers you wrote. And so you have a situation like All India Institute, which has 25 professors in cardiology. And unfortunately, nobody is interested in publishing. Some kind of incentive is required. And even before that, when this system wasn't there, the system of promotion was through Union Public Service Commission. There also merit would not prevail. You had publications, but somebody with know-how or with push and pull in PMO would get ahead of you. So you would also get disgusted and you wouldn't write any papers. The problem goes deep in our society. Some of us are actually carrying that flag. We keep publishing, we keep writing, and some of course do it a much better job actually. I have to appreciate more so actually, I don't know other fields, but in the field of endocrinology, our people keep publishing a lot all over.
Yeah.
I'm not too sure we are doing that well in cardiology or cardiac imaging. What are your thoughts? How should we incentivize? One of the things which I saw, I went to Echo Asia, I saw that all faculty which had been invited was one which had made original publications. Anybody who has not made original publication is not a faculty. So do you think in Cardiological Society of India or Indian Associate Radiology meeting, one could have that kind of stuff so that there is at least some compulsion to publish?
Similarly,
Yes,
from the
Yes, sir.
ASCI school, when you need to apply, the criteria is that how many original publications and the impact factor of the journal. So the weightage is given only for your original work. Case reports were also not counted in that.
That is true. Original articles are considered to be the most important publications. So weightage will be given only to original articles, no doubt about that. But by publishing case reports, we become known. And as I mentioned, that also is a learning experience. So therefore, we should keep publishing that also. But yes, for promotion purpose and for most of the academic benefits, whatever they are, original articles matter. Only original articles. But
Yeah,
sir,
but that is all over the world, but not in this country.
Not
this
in this
country doesn't make a difference. You are senior director, you want to become head of department, you think that it will make a difference? You have more publication than your boss? It just doesn't make any difference actually.
It doesn't make any difference at all. So the worst thing is that even whenever any speaker is introduced in our conferences, every speaker has many publications in national and international journals. That is a standard statement in every person's introduction, even if that person has had only one publication or no publication at all.
And some people put a number without even counting. Did they publish that number, 200 or 250? That is more surprising actually. Sometimes I keep thinking that I never saw a single publication. This guy is quoting 250 publications. Where were they actually? Or in Times of India or in Haas Khas Journal? Where were they actually? I just keep... But you know, still we need to actually have this this issue of pushing the younger generation to publish, because we would give them more importance if the society, forget the government and forget the incentive. If we feel that as a society, let us say IACI or Indian Academy will give you more importance, get you on faculty in case you publish and actually come on the forefront. We could do that. We will be doing a great service actually. The CSI is the Cardiological Society, and I can only talk about that. That doesn't look at what have you published actually, which area actually you are publishing. Now, quite often you are given topics to speak on which you have done no work. Quite often means 90% of the time. You have not done any work, they want you to speak on that. So this is also another area which we need to look into it. Why our record of publishing is so dismal, and more so in high impact journals. I don't know how to actually go about. And of course, you talked about that DNB, this thing, and DM students. At least I never found any of them coming up saying, I want to actually publish. I want to complete the thesis, not write a paper. In fact, most of the DNB students whose papers got published with them as the first author, I wrote everything, first page to last page, first word to last word, every table, every diagram, everything was made by me. But this is because we thought that these people would get some headway in life. I have never seen actually a single DNB student who had written a paper out of thesis and said, I have written it, can you check it?
Sir, but this is actually very uncommon. I used to come across papers published, written by DNB students. One can easily make out from the paper that who has written it. They used to be just like thesis, and similar papers get submitted to JIA also. And one can make out that these papers are written by the student only, and other authors have made no contribution to it. No senior has helped the student, and the student himself or herself has just written whatever he or she could do to the best of his or her abilities, and that is it.
So another thing which I wanted to ask, what is the role of the writing groups? Now we have professional writing groups. Most multinational companies have hired them actually, and they write on your behalf. Even if the original work has been done by a collaboration of 10 or 10 people, you submit to them the data and they look at it, they have their own statistician and they write it up. What is your view on that?
Sir, those who are good at that, they are very expensive. Most of the other medical writers who one can easily afford are not that good.
Most of these journals, the one which get into New England Journal of Medicine, I had a talk with John McMurray. He says we don't write it. It's written by the writing group is commissioned by Novartis, or let's say by somebody. They write it and they send it to us for our comments. He says most of the time we don't have to do much about it. They are so good. They're so professional. They are so thorough with everything: grammar, diction, syntax, setting the paper, writing everything. So that he says that you don't have to do anything except maybe go through it in a manner which doesn't look cursory, but at the same time you don't have to do anything great. That facility is not available with us. I think you are right. They must be costing a lot of money.
Very expensive, sir. Very expensive.
I actually once actually when the Novartis involved us in writing a toolbox for the heart failure patients. And I remember actually they came out with an excellent paper, and it did get into one of the journals with a impact factor of 3 or 4, I don't remember what. But I think they produced a very good paper, and we had nothing to contribute to that.
So these big pharma companies, they have resources to get that kind of writing group on board. Yeah. So they can help. But as individual author, it becomes very difficult.
Yeah, this is also probably one of the reasons why we don't write high quality stuff, because high quality stuff, if you do a work and somebody actually is sponsoring or supporting that way, maybe our quality would improve.
Yes, sir, definitely. Output will also improve.
Yeah, output would also improve. We can generate data, but somebody has to actually collate the data, analyze the data, write down the results. and then of course things will become all right. I see authorship of many of our friends in international journals. They haven't done anything except maybe contributed 10 or 15 patients to this multicentric study.
Yes, sir. I think from what you said, I'm thinking that we should ask pharma companies to provide this kind of support rather than other
Yes.
supports which are meaningless.
Yeah,
Travel
absolutely.
and, stay and all those things. Instead of that, they should be made to spend on these things.
I completely agree with you.
Sir, and I think as a team, since we'll have more cardiac imagers joining across the country, probably we can join hands and do some good work.
Yeah, but one of the important things is, as Dr. Manish said, and you also said that the case report don't make a difference. But if you have a series of cases, then it becomes an original work. So if we each of, let's say the case which was presented, first case or second case, and you have eight, 10 such cases, then it becomes a series. Then it is original work.
Sir, after Pudiwan presented his case, Dr. Jirish just wrote that he has similar 4 cases of coronary IG4 related vasculitis. So this is how probably we can get the data, and probably Jinish, why don't you take up this and collect all the features, make it as a.
But before that, this person has to know that, look, whenever I see such a case, I need to collect each and every information about the patient, because others may also have collected. We'll put together our resources. But like I said, the IGG, if you ask me to dig out that case, for me, it will be quite difficult. The reason is I never thought that somebody else would also join with me and we will publish this series.
Yeah.
If you have a priori, a group which is willing of 8, 10 people, and they do it, then you will keep the data of each and every patient, all images, all raw data, DICOM data, very, very carefully. Then it will make a lot of sense.
Agreed. So now I think definitely probably we all can keep and collecting the data and probably do some good work. I thank you, Dr. Manish, Dr. JC Mohan, sir. Thank you for joining us. And all my fellow colleagues. Sanjay, sir, are you there? Dr. Suman?
Yes, I am. Thank you. Thank you again.
Thank you, everyone. So we will close for the day. We will meet again next month. Thank you.
Thank you.
Thank you. Thank you.